بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning, good afternoon, good evening. Dear colleagues, it's my pleasure to welcome you all. It's my pleasure to welcome you all to our International Symposium, Egyptian Fetal Medicine Foundation Virtual Symposium. Today, our symposium will talk about the Hydrops Fetalis, current concepts in diagnosis and management. Let's see. Let me first welcome our guest speaker, our faculty speaker, Professor Sharif Fattah, Professor Badruddin Ahmed, and Professor Amal Sisi. Thank you so much for your time and for your lectures in advance. And now it's my honor to hand over the floor to our session moderators, Dr. Dalinda Chili, professor from Tunisia, and Dr. Sami Mahmoud from Sudan to start the
كده
first
يعني
session.
بس انا
Thank you
ظاهر
so
المفروض انا
much.
ظاهر
Let's start.
الكونتنت على الابلكيشن نفسه مش باين، كل حاجه ضغط على الكونتنت.
السلام
Good
عليكم.
afternoon. تفضلي داليندا، تفضلي.
أهلا، السلام عليكم. Hello everyone. I'm very happy to be here to moderate this session, this international session. Thanks for all of you and for Dr. Kemal. This session will begin with Dr. Sharif Abdel Fattah, who is a consultant in fetal medicine and obstetrics, South Mid Hospital, Bristol, UK. Vice President of the Royal College of Obstetricians and Gynecologists for Global Health. He will speak about fetal hydrops. If he is here, we can give him the possibility to begin his lecture.
Okay.
Dr. Abdel Fattah.
Right. Thank you. Can I just check? You can see my my slides.
Yes.
Yes, perfect.
Okay. Thank you very much. Okay. Thank you, Professor Dalinda, and thank you for Dr. Muhammad, Professor Muhammad Kamal Atman for the invitation. It's my pleasure to be here. And of course, the webinar is about fetal hydrops. And Professor Muhammad asked me to speak about recurrent hydrops fetalis in red cell immunization, focusing on diagnostic challenges and clinical management. It's not moving. Sorry, a problem. Is it moving now, the slides?
Yes, perfect, Professor.
Okay, fine. Okay, so diagnostic challenge. And the first challenge actually we have in these cases, which is focusing on recurrent hydrops in red cell aluminization. So the first challenge, is the hydrops really because of fetal anemia? And why are we asking this? Because of course we know about the prophylaxis revolution that happened from the 1960s when the anti-D was developed. And then it started to be used gradually until it became more widely available globally, which has led to about 80 to 90% drop in immune hydrops. So hydrops developing because of the red cell antibodies or specifically because of the anti-D antibodies. In other words, it's getting less common to see hydrops because of cases of anti-D alloimmunization. So when I see, so this is like a graph showing the decline in incidence of rhesus alloimmunization, and anyone who's involved in this field can tell the difference if you're old enough, working from 80s or 90s like me, and you can tell that the frequency where we see these cases is getting much and much less and gradually significantly less every time. It is estimated actually that the majority, of course, of hydrops we see is non-immune rather than immune. So immune is because of red cell alloimmunization, non-immune because of a variety of reasons. So about 90% of all cases of hydrops we see now are because of non-immune hydrops. Which means, of course, that the diagnosis is getting more and more challenging because you have so many possibilities you need to look for. And as my colleagues will talk in the coming discussions, things like infections, parvovirus, CMV, cardiovascular abnormalities, arrhythmias, a variety of structural chromosomal genetic abnormalities, metabolic disorders, all present with hydrops. And it can be challenging when you come across a case of fetal hydrops to tell what is actually the reason for the hydrops. We have to be aware that the anti-D, again, like several other medications and interventions that are relying on nationwide screening and availability of medication varies across the globe. So when we say that the anti-D has changed practice, it's available um, all over the world. Actually, this is not true. Some countries are better than others, and unfortunately, the West and um, the developed countries, developed nations, they have a screening program. They allocate the anti-D, they get the anti-D whenever it's required. But unfortunately, some countries, mainly in Asia and sub-Saharan Africa, it is still actually a very low percentage of women who are eligible for the NTD do receive it. So depending on where you work, which part of the world you work, or the population you're dealing with, even different parts of the world. So if I'm working in the UK, but I have a patient from sub-Saharan Africa, for example, or Asia, then we need to be aware that maybe anti-D was not given in her previous pregnancy. Okay, so first, how do I diagnose? So diagnostic challenges. What else? Early onset fetal anemia and severity. So subsequent pregnancies often experience more severe disease of fetal anemia, also starting earlier than in the previous pregnancy. So basically, on average, if a woman had experienced fetal anemia in a pregnancy, in a following pregnancy, the anemia is expected to develop on average 4 to 6 weeks earlier, and it tends to be even more severe. And then there is this very interesting condition called the silent hydrops, which is for some reason in subsequent pregnancies, fetuses can tolerate the anemia before showing the hydrops. So hydrops may appear later. So some recent studies reported that 71% of fetuses with severe anemia, which is hemoglobin less than 5 grams, did not demonstrate hydrops when you normally expect hydrops at slightly higher levels of hemoglobin. So it's an unexplained phenomenon that in recurrent cases, fetuses do not display the hydrops as expected. And then how you monitor this. Normally, we talk about the antibody levels or titers, and different guidelines in different countries identify different cutoffs. So for the anti-D, for example, anything more than 10 international unit, or for other antibodies which are measured in titers, not in levels, like cutoff of 1 in 16, for example, this indicates that there is a real risk of fetal anemia, and this is where you start referring to a fetal medicine unit and start monitoring for anemia. However, in recurrent cases, antibodies levels are not informative. They are not reliable. You can't just assume that because the anti-D is 8 or 7, that the risk of anemia is reduced. The antibody levels are completely unreliable, particularly if the woman was subjected to prior transfusion. Okay, next question. Is the fetus at risk of anemia? In other words, what is the baby's blood group? And of course, in the past, we used to do amniocentesis for fetal genotyping and finding the fetal blood group, but for many years, this is not required. So it's non-invasive fetal blood grouping using free fetal DNA in maternal plasma. How reliable? It is very, very reliable. And lots of studies, this have been one of the earliest work that was done on the pre-fetal DNA testing after the establishment of the trisomies, Down syndrome and other trisomies. The focus was on the rhesus D genotyping. And this is a big study from 2014. And it says that when done after 11 weeks, it's 99.8% accurate. And actually more recent studies getting even more and more accuracy. So the more recent studies saying that false negative rate in false saying falsely that the baby is D negative when the baby is actually positive has reduced to 0.05%. So actually it is not 100%, but it's not very far from 100%. And I think in many countries we completely rely on it. So if we know that a woman is immunized and we test the fetal blood group, it's negative for the antigen, which means not at risk of anemia, then we stop monitoring completely because we rely on this. And it's not only the D. So actually all other blood groups that are known to cause fetal anemia and potentially hydrops have been tested. So the big C, the small c, E, the KEL, all have been subjected to lots of studies. And you can see these guidelines saying we have not been informed of any incorrect results for all of them. So it is a huge revolution in managing these cases because, as I said, we used to do amniocentesis to test the baby's blood group, and this has stopped 25 years ago when we could rely now on these on the free fetal DNA testing. Okay, so we tested the baby. We know that the fetal blood group is positive for the antigen. There is a risk of anemia. So what's next? You need to monitor for features of anemia. And then you need to make a decision about intrauterine transfusion. And then after you do the transfusion, to follow up, further transfusions when needed, and then timing of delivery. So let's run through these things. And of course, again, we all agree that we rely on the middle cerebral artery Doppler velocity for non-invasive diagnosis of fetal anemia. I'm sure most of you are very much aware of this. It's not a new
لو
concept.
سمحت لي
أيوة.
بروفيسور شريف الصوت واطي حبتين. Can we
واطي.
increase the voice please?
I think this may be from your end. Yeah, is this any better? I think it's from your end.
Now it is better.
Okay, that's fine. That's fine. Thank you. Okay,
Yes,
right.
thank you.
So, yeah, the middle cerebral artery Doppler velocity, why is it increased in cases of fetal anemia? So basically, in cases of anemia, there is decreased blood viscosity because of the breaking of the blood cells. So the blood is thinner. And there is increased cardiac output because of the heart failure that is accompanying anemia. So there is rise in the velocity. So basically, the blood is thinner. There's increased cardiac output, so the heart is pumping stronger to compensate for the poor quality of the blood, which means that the blood will go faster. And you can measure this in all blood vessels, but it's measured in the middle cerebral artery because normally the head is in the pelvis fixed, so it's easier to measure than other blood vessels. So how can you define anemia? So the clinical threshold is when you measure the peak systolic velocity to be higher than 1.5 multiples of the median for gestational age. So this has been validated and has been proven to identify moderate to severe anemia. And that's really important because you don't want to wait for anemia to be very severe to intervene. And also you don't want to intervene too early when it's only mild and the baby is not at real risk. So it is validated that it can detect moderate anemia that is likely to progress to becoming severe, and therefore it justifies intervention. How early can you rely on this? Reliable measures can be from as early as 16 weeks gestation, and yeah, but it has, of course, to be managed in specialized units, tertiary fetal medicine units. Sorry, having a problem again. Sorry, it stopped moving. Sorry, I'm trying to solve the problem from my end here. Okay. How reliable? So actually, It's not a new concept, and I personally did a lot of work on this many years ago. It's got 25 years ago now. So this is one of the original work we've done, how reliable the middle cerebral artery Doppler velocity for the prediction of fetal anemia in cases without hydrops. And as you can see from this graph here, significant difference, very highly statistical significant difference between the MCA velocity in anemic versus non-anemic fetuses. Sorry, this is again not working. Okay. We also found that in anemic fetuses, those with hydrops, the MCE velocity is higher than, in patients presented with hydrops, it can differentiate between hydrops because of anemia versus hydrops because of immune cases, non-immune cases like non-anemic fetuses. So you can see in this a paper published here again 25 years ago, you can see that the MCA velocity in hydropic anemic fetuses is again much higher, very high statistically significant difference from the non-anemic fetuses. Right, so when we manage these cases, we are faced with difficult decisions. Diagnosis of fetal anemia, when to do the first transfusion, and then timing of subsequent transfusions. And is it always the difficulty? Is it safe to delay invasive testing? So you rely on this non-invasive method that it is perhaps subjective. It does not tell you exactly what the fetal hemoglobin is. Can you say, okay, let's wait for another week or two, or you're getting too worried that by delaying things, you're putting the fetus at risk? So to diagnose fetal anemia, as I said, it can start from 16 weeks. How frequent we do this? Again, we've done some work on this, and every 2 weeks seems to be reasonable when there is significant alloimmunization. And you continue till delivery, although we accept that the reliability of the MCA Doppler velocity reduced after 35 weeks, but you don't have other options, so you continue till delivery. And as I said, you measure the maximum velocity. You use cutoff more than 1.5 multiples of median for gestational age, and there are normal charts for the velocity, like anything else for the MCA velocity in correlation with gestational age on any fetal medicine database, and also they are available online. Okay, invasive assessments. So now we need to do something because we think the fetus is anemic. So when do we make that decision? Traditionally, it used to be you wait until there are ultrasound signs of fetal anemia. Hydrops, hopefully you don't have to wait until hydrops, because hydrops means severe anemia, but early sort of pre-hydrops features indicating compromise of heart function because of the anemia, like cardiomegaly, polyhydramnios. And then there was this interesting 10 weeks rule, which is 10 weeks gestation earlier than the previous pregnancy complication, whether the baby died and sudden death, or developed hydrops, or required transfusion, or delivered and required exchange transfusion. So 10 weeks earlier, this is when it was expected that the anemia may start to kick in and be severe enough to require intervention. Of course, it was not based on any scientific evidence. It was just observation, and because there were no other tools. In reality, it was when the fetal medicine specialist becomes too worried. I can't wait anymore. Am I putting the baby at risk? And then the next question is what procedure to do. Traditionally, it used to be chordocentesis. So you put the needle into the cord, take a sample of sample of fetal blood, you measure the hemoglobin, and then if it is low, then you bring the patient next day, you prepare the blood for transfusion, and you do the transfusion then. And then it was very often that you measure the hemoglobin and it's not anemic, so you don't have to do something, and then you repeat again the chordocentesis a week or a few days later, depending on the situation. As you can imagine, each of these procedures carries risks. So now it's completely abandoned because of the risks. And you completely rely on the MCA velocity. When the velocity is increased, then this is when it's indication that the fetus is anemic. So what procedure? You do it as one procedure. So what we do, chordocentesis with the blood ready for transfusion. You take the blood sample, you have a local, it's called culture machine or different machine just to measure the hemoglobin, even the blood gases machine that you can use on labor ward to measure the fetal blood gases. It can give you the hemoglobin. So you take the sample, someone do it quickly. It takes about 5 minutes for the results to come back. And if it's confirmed anemia, then you go ahead with the transfusion. So it is just one procedure rather than doing two procedures. Let's talk about the intravascular transfusion. We all know about this, what sort of blood you give. It's group O negative. It has to be screened for all possible viral infections. And of course, you have to give the fetus a small volume. There is no need to give the baby too much plasma. Baby, of course, is small. There is already compromised heart function because of the anemia. You don't want to overload the baby with unnecessary fluid. So you need the baby RBCs. So it's packed RBCs. Hemoglobin is about 24 to 29, very high hematocrit levels here. It has to be leukodepleted by filtration to avoid infection. It has to be irradiated because it's a foreign body to the baby. You don't want the baby rejecting this. So it needs a lot of preparation and it's quite expensive. And you don't want to waste it. So you give the fetus a small volume because the baby is small. And as I said, you need to give the baby the maximum benefit. There is no need to overload the baby with unnecessary plasma. So it's packed RBCs. Next question, how much do I transfuse? You aim to increase the hemoglobin to 2 standard deviations above for the gestational age. So you can see on the graph here, these are actual cases we looked after. So the arrows here showing the pre-transfusion hemoglobin going up to the post-transfusion hemoglobin. The lines here are presenting the normal range. So the average is the one in the middle, 50th centile, and then 2 standard deviations above, 2 standard deviations below. So relying on the MCA Doppler velocity, you can see all these transfusions. By the time we did the transfusion, the fetus was significantly anemic. It was justified to take the risk. And then the aim is to give the baby enough blood to raise the hemoglobin to 2 standard deviations above gestation for the gestational age. But you have to be aware in hydropic fetuses, heart function can be or is compromised. So you don't want to overload the fetus again. They may not cope with the volume of blood you're giving. You deliberately give the fetus less volume transfusion. You know it will not raise the hemoglobin to the extent you need, but because you balance the benefit and the risk. If you give the baby too much fluid, then the heart may not cope with it, with a high risk of fetal death. So it is, as a compromise, you raise the hemoglobin enough to sort of relieve the danger, and then you will have to repeat the transfusion sooner than probably you would like to, but because it's the balance between the benefit and the risk of the transfusion. So how much transfusion I give? There is a formula which you can see here. It is calculated by sort of the fetal placenta blood volume, which is this formula here, the estimated fetal weight in grams, and then you work out the donor hematocrit, which is the packed RBCs you're given, what is the fetal hemoglobin and what is the desired hemoglobin you need to reach to. And there are online calculators. So again, fetal medicine databases that are used in most fetal medicine units like Viewpoint or others, they do have this embedded. But if you don't have it, you can get online to several websites like this one, perinatology.com, or the Fetal Medicine Foundation, or the ISUG, and it will give you this online calculator. You can input gestational age, donor hematocrit, the desired fetal hematocrit, and the estimated fetal weight, and it will work out for you how much blood you need to give. Complications of transfusion, of course, we know volume overload, bleeding, fetal bradycardia, infection, ruptured membranes. So it is a really risky procedure. Overall fetal loss risk is 2 to 3% per procedure. So the more procedures you do, the more cumulative risk there is. And it's interesting, we get better at things, but the fetal loss risk actually is more or less the same because we do less and less of them now. So when I started my career, we used to do like 3 transfusions every week. Now it's 1 every 2 months. So actually, we get less killed. We do less of them, and therefore the risks are more or less stable. Then the next difficult decision: when do I do the subsequent transfusion? So I did the transfusion. I gave the baby enough blood to raise the hemoglobin to 2 standard deviations above the mean for gestational age. But of course, this blood will be consumed. It will not stay there forever. So when do I do the next transfusion? It is estimated that hematocrit fall by 1% per day, which is equivalent to 0.35 gram per deciliter. So allowed to fall to a reasonable level. So again, as we said before, hemoglobin of 5, for example, that's too low. Hemoglobin of 10 does not justify the risk of giving the transfusion. So allow it to fall to around 7 to 8 gram. You work out your post-transfusion hemoglobin. You take a blood sample at the end to measure the hemoglobin, and then you allow it to drop to this level. So you work out how many days this will take. Usually, it's every 2 to 3 weeks you have to repeat the procedure. Again, fetal hydrops, it make the hemoglobin consumed quicker than when there is no hydrops. Again, this is some study we've done many years ago, showing the rate of fall of hemoglobin in cases of hydrops compared to the non-hydrops. And you can see it is much higher in cases of hydrops, which means that you will need to give the transfusion more frequent or sooner than in cases with no hydrops. And this is just a real case when we relied on the transfusions. So you can see measuring the middle cerebral artery Doppler, you see with the first FBS fetal blood sampling and transfusion, this is when the MCA Doppler crossed the higher level. And then after the transfusion, you can see it is down to the average and then gradually rising until it became again above the normal range. And this is when we get the second transfusion. What are the neonatal outcomes? It is very good. So survival rates estimated to be about 92% in non-hydropic fetuses. Unfortunately, it is less in hydropic fetuses, although again, it's getting better because hydropic fetuses are higher risk. They are already having heart failure. They are already very, very much compromised. They do not resist they do not cope with the stress of the transfusion. What about cases when anemia developed too early? So the earliest you can do intravascular transfusion is 20 weeks, 18 if you're stretching it too much. Why can't you do it earlier? Because the cord is very thin. You can't really do it technically, but also with the cord very thin, it will bleed a lot. So little hole in the cord, it will bleed a lot. Babies too small do not cope with it. So actually 18 is the earliest, but 19 to 20 weeks is the more practical thing. So it is too early. So if you come across a fetus who's developing anemia before 18 weeks, which does not happen very often, but it does happen. Another alternative for the intravascular transfusion is the intraperitoneal transfusion, which can be done, just put the needle into the abdomen and inject some blood. It's not ideal, but it can be done in early pregnancy. But unfortunately, it does not work in hydrops because if the already fetus has ascites, it will not absorb the blood. So what can you do? You have these strategies, the maternal IV immunoglobulin. By giving high dose intravenous immunoglobulin, it reduces the antibody's activity. So it does not eliminate the antibody, of course, but it just the activity, restrict the activity, so reduce the rate of fetal hemolysis. Plasmapheresis, plasma exchange, that is a little bit more of an extreme because you remove the plasma that carry the antibodies, put another. It's a very, again, risky procedure. Both are very expensive. Both carry, so the maternal IVIG is very expensive. The plasmapheresis, the plasma exchange carry all the risks that come with blood transfusion, the same risks, because it's a sort of blood product transfusion, but also with the exchange, it carries other risks. But sometimes you have to resort to because there is nothing else you can do. But we have to remember that these are complementary, just to keep going until you can do the transfusion. It's not a substitute for the transfusion. And as I said, it's only for women when there is very early severe disease that baby is likely to die before you can technically do the intratrans transfusion. Lastly, when do you deliver? 36 to 37 weeks is the agreed maximum. Usually it is within 2 to 3 weeks of the last transfusion, and it's unusual to do the first transfusion after 35 weeks. So if you come across anemia like 35 weeks on balance, the risk of the procedure can be balanced by delivery at 35 weeks. And there is no reason to go for cesarean section unless there are obstetric reasons. So there is no reason why can't you induce labor. That's it for me. Thank you very much. I will stop sharing now.
Dr. Sharif. It
شكرا
was,
جزيلا
yes.
Professor Sharif Abdel Fattah.
Sorry, I'm
Thank
trying
you
to
very
stop
much
sharing. I
for
can't do
the
this.
nice
Just
and informative lecture. It was really amazing. We have opened the floor for discussion. We have asked the audience to write their questions in the discussion in the chat box. I'm not sure if Dr. Tamir Farid is with us. Tamir, did you collect some of the questions from the candidates?
can you stop
Yes,
sharing from your
Professor.
end? I can't do it actually. I'll stop sharing here. Yeah, okay. I stopped sharing now. Good. Yeah, happy to take questions now, or if you want to leave till later, I'm happy with whatever you want.
اوكي دكتور شريف، في سؤال في الشات بوكس. management of case with RH negative who didn't receive the anti-D in her previous pregnancy, and she's now pregnant for the second time and not immune.
Okay, so if she's not immune, then that's fine. Perhaps the fetus was rhesus, the first baby was rhesus negative and the current was rhesus negative. So yeah, if she's not immune, then that's lucky escape from the first one. And yeah, I mean, just follow the same. So if you have the facility of testing the fetal genotype, the fetal blood group by free fetal DNA testing, if the fetus is negative, then there is no risk. If the fetus is positive, then you need to keep monitoring by measuring the middle cerebral artery Doppler, as I said, start from 16 weeks. But also in this case, if she's not immunized, then you can rely on the titers. If the titers still continue to be negative, then there is no risk. If titers start to develop, then you need to monitor them depending on different countries' guidelines. I think usually it's every 4 weeks until 28 weeks, and then every 2 weeks from then. And if the titers reach the level, so again, the anti-D is usually measured in international unit. Other antibodies are titrated. So if the antibody levels reach the critical level or the titers, then you start monitoring with the middle cerebral artery Doppler and proceed with the intervention as discussed.
Another
Perfect, thank you.
question, Professor Sharif. Should middle cerebral artery Doppler be done routinely to all patients?
All patients in general, or you mean at risk of anemia?
In general.
No, there's no reason to do this. The middle cerebral artery Doppler, it's used for two things. Either cases of anemia when you measure the velocity. So you have, I mean, the woman need to be at risk of fetal anemia for some reason, either because she's immunized or because of parvovirus infection, for example. But it can be used for the resistance in cases of growth restriction or placental dysfunction. So again, depending on the indication and the pregnancy progress, but there's no reason to use it for everyone. It's not screening for anything unless there is risk factor. So either risk factor for placental insufficiency or risk factor for anemia.
Another question, what is the best time to start screening in rhesus negative ladies?
Yes, as I said, if the woman is known to be rhesus negative, then no antibodies, so she's not immunized. Then what again differs between different countries, but at least you need to do a sample at booking and then another sample at 28 weeks. And that's a different subject now, of course, with the prophylactic. So woman who is rhesus negative, not immunized, you should give anti-D postnatally. but also if she's subjected to any sensitizing event during the pregnancy, like abdominal trauma or bleeding or amniocentesis or something like this. But then, of course, there is the routine antenatal prophylaxis to guard against the silent prophylaxis that can happen. So the recommendation is to give 1,500 international unit of NTD between 28 and 32 weeks.
Thank
So
you,
that's
Professor
assuming the woman
Sharif.
is not sensitized. Yeah.
Thank you. Another question is, what is the best time to deliver a baby with anemia?
Again, national guidelines vary, but if the woman did not have transfusion, then the UK, the national recommendation, the college guidelines is to deliver between 37 and 38 weeks. That's assuming there are antibodies, but intrauterine transfusion was not required. The reason for this is that there have been reports that the antibodies, even at low levels, start shooting up all of a sudden at the very end of the pregnancy. So to avoid this, the recommendation is to deliver between 37 and 38 weeks. If a woman had transfusion, then no later than 37 weeks, so between 36 and 37 weeks.
Thank you, Professor Sharif. Another question from the audience. You mentioned that in blood transfusion, the blood should be radiated. What is the
Irradiated.
meaning of irradiated? What is
So
the
radiation.
meaning of irradiated?
Irradiation to stop it's like giving any organ transplant here. So you have to do irradiation to reduce the reaction that can. So it's done in sort of radiotherapy machine basically to reduce the sensitizing reaction that can happen to the fetus of giving a foreign body to it.
Another question from one of the audience. In twin pregnancy with monochorionic diamniotic pregnancy, anemia has occurred in one fetus and the other fetus is polycythemic. Can blood transfusion to the fetus with anemia be done?
Yes, if cases of twins, only one is sensitized and anemic, you can give the blood transfusion to the one fetus who need it. Of course, technically, it will be more challenging and difficult. But anyway, these cases have to be managed in specialized centers, particularly that are getting less and less. So, as I said, when I started my career, we used to do 3 transfusions per week. Now it's really once every 2 months if we have to. So it's really important that these are high-risk cases. Interventions are risky. Decisions have to be made at the right time, and they have to be managed in specialized centers.
Thank you very much, Professor Sharif. We really enjoyed your audience.
Can I ask 2 questions, please?
Please, Dalinda. Yeah.
شكرا. First, I would like to know in the UK is antenatal determination of fetal blood by DNA is classical or is dedicated? Is it
routine? It is routine
or not?
Yeah.
Really?
So it's routine now for all women who are rhesus negative. They are offered the free fetal DNA testing blood grouping from 16 weeks. So the studies I mentioned, they said this can be reliable from sort of 12 weeks, 13 weeks, but the labs actually ask us to make it 16 weeks to make it sort of more reliable. But also because the fetal immune reaction does not develop that early anyway. So it's very, very unlikely that the fetus will be developing anemia before 16 weeks. So what we do is offered routine to anyone at 16 weeks.
Okay. The second question, are there specific centers in the UK for this kind of problems? يعني immunization, I don't know.
Because the numbers are getting less and less, so they are centralized in tertiary centers in each region. So in each region there will be one referral center to deal with these cases. Yeah.
Okay, and the last question.
Even Dalinda, within the same center, there will be only 1 or 2 consultants doing these cases, because again, with the small numbers, you can't have 6 or 7 consultants doing them. But by the rate we're seeing now, it will be less than once a year if you do this. So it's focused within just 2 people to gain the experience. Yeah.
The same problem in Tunisia.
Yeah. Well, it's
And
not a problem. I mean, it's good that the
أي
cases are less. Just to
الحمد
maintain the
لله.
skills. Yeah. To
Yeah.
maintain the skills, yeah, you need to
Yes, for the
focus
skills
more.
is a
Yeah.
problem.
Yeah.
The last question, are there guidelines about when to give anti-D regarding the term of pregnancy? Some people say less than 7 weeks, it doesn't make anything. Some people say no, if she is rhesus negative and the husband positive, anyway, you have to do it at any time. Are there
No,
guidelines?
yeah, there are lots of guidelines, the Royal College guidelines, which actually have been adopted by the British Hematology Society. So it's now one guideline, and of course, American College and I think ISIOC also, they may have guidelines, but basically. We don't give anti-D for events before 12 weeks. So like spontaneous miscarriage or threatened miscarriage. Yeah, I think even before 10, 11 weeks after this, yeah, you don't need to give unless there is heavy bleeding or ectopic pregnancy, because of the internal bleed can happen. But for spontaneous miscarriage or mild threatened miscarriage, we don't give anti-D before 11 weeks.
Okay, thank you very much.
Yeah.
Dr.
Very
Sharif,
interesting.
Professor Sharif,
yes, Dr.
thank
Sharif,
you.
I have question, Sami. Is it okay?
Please.
Yes, okay. Go
Okay,
on,
Dr.
Professor.
Sharif, thank you so much for your outstanding lecture. I wonder about the method or the technique of intrauterine blood transfusion. What's your opinion and experience about intrahepatic, about intraamniotic fluid transfusion?
Intraamniotic, I don't know
Yeah.
about intraamniotic, but intrahepatic, it is an interesting one because, of course, as the images I showed, it's always easier when the placenta is anterior and you can reach the cord. And actually, when the placenta is anterior, it helps a lot because when you put your needle, it's fixed within the cord, does not deviate, within the placenta, does not deviate. But of course, you have to aim, accurately into the cord. When the placenta is posterior, of course, it's more difficult because you can have the baby on front. You can have, with the BMI, for example. So posterior placenta can be a bit tricky. Can I put a picture here of a posterior placenta? You have to go from a different angle to avoid all these things. But sometimes it's impossible to reach it, either because the baby's lying on the cord or the placenta. So intrahepatic transfusion is a good option. And actually is not as difficult as it may sound. But again, you need to maybe be in a good position. It has a different technique. So basically you aim for the liver and you have to push really hard with the needle. You go, so what you do, the hepatic vein of this, you go through it and then you withdraw the needle to get into the hepatic vein. If you try to aim to get into it, you will keep fiddling and there will be bleeding. So the better you go through it and then withdraw the needle to get into the lumen of the intrahepatic vein. It is a good procedure and it's not as difficult as it may sound, actually. The other interesting one is the intraperitoneal transfusion, which sometimes we have to do when anemia develops early, like 16, 17 weeks when you cannot do intravascular transfusion. And the way you do it, the needle inside the fetal abdomen and you start injecting blood. So you're creating, you watch, observe on the screen, watching ascites developing because you're putting the blood into the peritoneal cavity. It's not ideal, but it's still the blood gets absorbed and you don't have another alternative.
Okay, thank you so much. Yeah.
We have hell of questions. I'm sure we cannot go through all of them because we have one more or two speakers, but we have one more question.
Sorry, I
Professor
see a
Sharif?
question here that's really important. So someone asking,
Yes.
even surgical intervention before 12 weeks, anti-D not given? No, if there is surgical intervention, you have to give the anti-D. What I said is if there is spontaneous miscarriage, you don't have to. But with surgical intervention, yes, you have to give it.
Another question, what is the best treatment protocol for giving anti-D? Is it single dose at 28 weeks or two doses at 28 and 32 or 34?
Yeah, the antenatal prophylaxis started with 2 doses, 28 to 32 weeks, and then it was I think 500 international units at the time, and then for cost saving, it was studies that was found that you give 1 dose of 1500 at about 30 weeks, between 30 and 32 weeks, that's enough. So either 500 units at 28 and 32, or 1500 unit at about 30 weeks, both are efficient.
Thank you very much,
Thank you
Professor
very much,
Sharif.
Professor Sharif. I have a question, if you allow me, Sami.
Yes, please go on, Ahmed.
You know, Professor Sharif, that we are living in a middle and low resource countries, and so the antenatal care is not as good as we expect. So my question is, most of the cases that are sensitized and at risk of developing fetal hydrops came to the antenatal care with fetal hydrops already present. So what is the best management for anemic fetuses with current fetal hydrops?
Yeah, I mean, as I said, I mean, you have to monitor, and so if presenting already with hydrops, and you know that the hydrops is because of anemia, not because of some other reason, then your only option is the intravascular transfusion, which of course I know it's expensive, it's a big deal, but there is nothing else. I mean, baby's anemic and it has to be corrected, so it is the intravascular transfusion, but with all the precautions I discussed. So again, with the hydrops, you need to give less volume than in non-hydropic fetuses, which means you will have to repeat the procedure again sooner than 3 weeks, usually 2 weeks, sometimes even sooner than that. But yeah, transfusion is the only possible way.
Many of the cases that we have encountered in the unit with current fetal hydrops, the fetus is not surviving after the initial transfusion, even though we managed to give or transfuse only a small amount of packed RBCs. So they can. So if we are just near to term or in the region from 28 to 32 weeks, is it wise to deliver the fetus and manage the exchange transfusion outside, or
well, of course,
it
depends on the neonatal unit facilities. So you have to discuss with the neonatologist, because again, you have to remember that if the neonatal unit normally can cope with a 28 weeks fetus, 28 weeks baby, that's talking about 28 weeks healthy baby, but 28 weeks anemic, heart compromised baby, that's different. So it's not only the cutoff of gestational age, it is the condition of the baby. So 28 weeks or 26 weeks or 30 weeks healthy baby, that's different to 30 weeks growth restricted or have congenital anomalies or have heart abnormality or anemic fetus. So it has to be discussed with the neonatal units.
Thank you very much. The floor is yours, Dr. Sami.
Thank you.
Thank you very much. Thank you very much, Professor Sharif. I guess this is the end of our first session, first lecture. We have been honored by your presence. We have more than 250 audience, and that is a record to our symposium and presentations. Thank you, Professor Sharif.
I hope I did not take too long. I didn't notice how long it was.
We enjoyed it anyway. We have enjoyed it.
Thank you.
And
Thank you very
the
much.
audience has enjoyed it, and the questions are still coming, but we cannot go forever. We have to stop, and we are looking forward to meet you again in another presentation hosted by the Egyptian Fetal Medicine Foundation. Thank you very much, Professor.
Thanks, Dr. Sharif. Thank you so much, Dr. Sharif, for your time. Appreciate. Yeah, perfect.
Thank you.
Our next speaker will be Professor Badruddin Ibrahim Ahmed. He will speak from Qatar. He is the founder of the Fetal Medicine Unit at Hamad Medical Corporate, and now he is the lead in fetal medicine at the Maternal and Fetal Medicine Center in Doha, Qatar. He has a professorship from Weill Cornell University. He is a renowned professor and teacher in obstetrics and gynecology and in the Ian Donald School worldwide. We will enjoy his talk today about hydrops fetalis in twin pregnancy. The floor is yours, Professor Badruddin Ibrahim Ahmed.
Assalamu alaikum. Thank you all for inviting me. I'm really privileged to be here. Can you see me?
Yes, Professor.
Can you hear me?
Yes, Professor.
Do I look handsome?
As always. As always.
Right. Okay. when Mr. Muhammad, my friend, asked me to speak about high drops in twins, I thought, oh, this man is giving me trouble. So I actually really went back and tried to find out why is this an important question. And in the coming 20 minutes or so, I will try to answer this question to the best of my knowledge. Now, high drops definition, I'm not going to speak about definition because here you know what the definition of high drops. But high drops is very interesting because it is a real dilemma. There is many roads lead to the same phenotype, which is called high drops. Now, if you look about the pathophysiology of high drops, you're going to find that it's either due to leaky capillaries, like case of septicemia, or decreased oncotic pressure, like case of liver and renal failure, could be to hydrostatic pressure due to heart failure, or could be due to lymphatic obstruction, like cases of cystic hygroma. But in our case of twins, the pathology physiology is here: increased hydrostatic pressure as a result of impending heart failure. When we translate to twin, that is completely confined to monoclonic twin pregnancy. So the high drops causing general high drops with regard to twins is almost exclusive to monoclonic twin pregnancy. Of course, a twin pregnancy can develop high drops to many other reasons, but if you call the twinning phenomena itself, the only twinning phenomena which can cause high drops is related to confined to monoclonic twin pregnancy. That has to be made clear from the onset. Now, and that's why it's so important to determine chorioamnicity, whether you do it by fetal sex, by placenta, by intermembrane thickness, by lambda sign, by yolk sac. But it's the most important one and the most reliable one and the most scientific one and the most practical one is here, the lambda sign and the T sign. And I'm not going to waste your time, but you all know about lambda sign, and is here the chorion go inside the membrane. I just want to warn you, when you see this sign, there is lambda sign, that is dichoric twin pregnancy. But please put your color Doppler here, because sometimes there will be the cord, and that will deceive you. Now, when you diagnose chronicity in the first trimester is as good as histopathology, which means that it's a very reliable diagnosis. T sign for monoclonic, lambda sign for dichoric twin pregnancy. Why this is important? For many reasons. It's important for screening diagnosis, about complications, and also when we decide to interfere surgically. We need to know, is this twin pregnancy mono or dichoric? And I always tell my student and my audience that twins pregnancy is double trouble, never a double joy. Because if you look here, compare singleton to twin pregnancy, you'll find a high miscarriage rate, high pediatric deaths, growth restriction, preterm labor, etc., and malformation. But more to that, if you compare monoclonic, dichoric twin pregnancy, again, there is a huge difference between monoclonic and dichoric. Monoclonic twins pregnancy having a higher chance of miscarriage, prenatal death, IUGR, preterm delivery, and malformation. So it's critical to determine chorionicity from the start. So what is the story? What is the whole thing is about? If we have dichoric, it means they have two placenta. The placenta is formed of cotyledon. The functional unit of the placenta is the cotyledon. Every cotyledon have got an artery and a vein, which go to the same baby. And on this baby, artery and a vein, which go to the same baby. So there's no issues here in dichoric twin pregnancy. But in monoclonic twin pregnancy, you have the cotyledon. In the cotyledon, there will be two vessels. One goes to one baby, and the other vessel goes to the other baby. So they're sharing cotyledon. They're sharing circulation. They're sharing complication. That is the fundamental difference between monoclonic and dichoric. It's a shared cotyledon. And that's how it looks like. And this is probably the most important slide of my talk. There should be no report reading twin pregnancy. It should read either monoclonic twin pregnancy or dichoric twin pregnancy. To the extent that some people recommend that if you have a report from a colleague who is saying only twin pregnancy, the advice is this report is completely meaningless. It's so important. Now, for monoclonic twin pregnancy causes complications which can lead to high drops. Twin transfusion syndrome, twin anemia blood thalassemia sequence and selective IUGR. And I'm going from now on to use the term TTS for twin transfusion syndrome and TAPS for twin anemia blood thalassemia syndrome, and then I selective IUGR. I'm not going to speak about TRAP, but this condition can cause hydrops. They can coexist together in the same patient. Now, what is the real problem here? And I give you a very important summary. TTS is a problem of unequal volume sharing. One twin having more volume of blood than the other twin, while TAPS is unequal RBC sharing, and that is because of the small vessels and the chronic, slow, simple sharing of blood. IUGR is selective IUGR. The sharing of nutrition is unequal nutrition. And if you look at this area, which is called vascular equator, one baby have got a big share of placenta, the other one have got a small share of placenta. So these are the summary of the problem. In TTS, we have unequal volume sharing. In TAPS, we have unequal RBC sharing. And in selective IUGR, it is unequal nutrition sharing. So let us spend some time in twin transfusion syndrome or TTS. As I said, it's unequal blood volume sharing, and it can happen as early as 16 weeks of gestation, most probably at 10 weeks. It can affect about 15% of the twin pregnancy. And here is the question. If we have TTS and not treated, the mortality is as high as 80%. So the question has to be addressed. So there is in TTS, there is a donor and there is a recipient. The donor pump blood, the recipient receive blood, and they are both in danger. This is given to me by my friend a long time ago from Hong Kong, my friend Professor Lei. And you can see here what just saying here, that you've got a two placenta, two babies sharing one placenta. What's going to happen? There is a crossing of the blood from one place to another place. And if the crossing is sort of equal, there should be little problem. The problem will happen only if there is more blood going to one direction to the other. And that's like here. So here you're going to find there is more blood going from this way to the other side. There's not equal volume. As the result, this baby, who's very generous, will become hypovolemic, become anemic, cannot form urine, become oliguria, and the blood will be small. So it will be IUGR, and we call it stuck twin. That is the one who is giving blood. The other one, again in trouble, because they have polycythemia, polyvolemia, polyuria, big bladder, polyhydramnios, cardiac failure, and hydrops appear. That's where hydrops come in the equation. And this is a full-blown picture of TTS. So what happened after that? This baby who is generous is gonna most probably consume and die, and the other one will try to save his co-twin. And as a result of this activity, the surviving twin may develop cerebral palsy in about 30% of the cases. So it is a disastrous condition. TTS, if severe, it is disastrous and take an action. So diagnosis, as I say, is as early as 16 weeks of gestation. Normally single placenta. There will be polyhydramnios in one twin and oligo in the other twin. And you can see in this picture, there's polyhydramnios here and there's oligohydramnios here, and they call what we call a stuck membrane. If you look at the bladder, you will have a small bladder, and the other one will have a big bladder. So polyhydramnios, oligohydramnios, big bladder, small bladder, and then you have no changes in umbilical artery Doppler. That is where things become worse. So we're moving from oligo, poly, small, big bladder to uterine artery, so umbilical artery Doppler changes. And that is a summary by Contiero. What I want you to look at, I don't like this slide, but here what we concern: oligohydramnios, polyhydramnios, absent bladder, big bladder, abnormal umbilical Doppler, and then they develop hydrops. That is where hydrops come in the twin. And then eventually, if not treated, you'll have IUFD. That is the question. So what to do? There is only two solutions. One, amyloid reduction, and the other one is coagulation of the chairing vessels. Amniocentesis or amyloid reduction is done by amniocentesis, which is a simple procedure. You put the needle, you take Liker and repeat the procedure. Take 1 liter, 2 liters, depends. It is a simple procedure. There's no cost. You can do it in any clinic, in أسيوط, in الواحة الصغرى, الواحة الكبرى, in Sudan, in Tunisia, wherever you want. Where any office can do it. It's a simple procedure, but it does not treat the condition. It cannot prevent the effect on the fetus. It has to be done multiple times. The risk of rupture membrane is not that big if you are experienced, and then the chance of cerebral palsy. So if you are desperate, there's nothing else to do, we advise you to do serial repeated amyloid reduction. And that will be the only thing you have in your hands. And I think that will apply to many of the audience in this group. So if you have the condition, you don't have laser facilities, that's what you do. Repeated serial amyloid reduction. The other option will be is to laser the invading vessels and aim to go at the vascular equator and laser the bleeding vessels. I'm not expert in this because as Dr. Fatah was saying, these procedures are becoming less and less, and the number of people who specialize become more or less, and that's how you do it. I'm just giving you this video. Hopefully it will show. But the advantage of lasering is it targets the disease itself, and it is a single treatment. You put your needle and you put the ultrasound guidance. Once the needle inside, you can look at the placenta. This is your ultrasound, and you put your fetoscopy. So you have two monitors now. You have the ultrasound monitor and you have the fetoscopic monitor. And then you hope to aim at what we call the vascular equator. And your vascular equator, you try to ligate the communicating vessels. So what you are doing basically, you are making this monoclonic placenta diclonic placenta. It's a function, it's anatomically one placenta, but you are making it a functional like two placenta. So the aim of the laser therapy is to convert this anatomical monoclonic placenta to a functional diclonic placenta, as if there are two placenta. It is, as I say, it's not actually that difficult technique, but it's a little bit expensive, and it should be done in a specialized center. And if you do it properly, and you have in many cases, the outcome is very good, and it's very effective therapy. So I come back again to my main slide. So I kept telling you that TTS is the problem of volume. Now I'm going to speak a little bit about TAPS, which is twin anemia polycythemic sequences, and I'm going to use from now on the term TAPS. So TAPS is unequal RBC sharing. What happens? That you have this. I came back to my drawing again. You have one placenta, you have the cotyledon coming together, an artery from one baby to the vein and the other baby, or vice versa. And there is a small anastomosis. The anastomosis is very small. And that's why there's a chronic diversion of the blood. And that leads to unequal RBC sharing. Again, there'll be a donor and there'll be a recipient. The donor who's moving blood will be anemic. The recipient will be polycythemic. As the result of that, for anemia in the donor, you're going to have high porosity in the middle cerebral artery Doppler, and this one will be normal or less. But the other phenomenon is reticulocyte formation, and that people will normally ignore this. As the result of fetal anemia, people will not sit down doing nothing. People will fight. So the liver will work extra hard and give you increased incidence of reticulocyte fraction. These changes allow us to follow this patient. The changes, the anemia, allow me to follow this patient. The liver activity allow me to follow this patient. How that happen? So the anemia, I'm going to see the signs in the cerebral artery, and I'm going to see the signs in the placenta. In the liver, I'm going to look at the fetal liver, and I'll show you in a minute. So this is the TAPS, twin anemia polycythemic sequence. As I said to you before, Here, the blood transfusion is chronic in a small amount. It's less than 15 millimeter per day. That was the estimation. And that's why this condition, you have to be looking for it. It could be coexistent with TTS. It could be happening after laser for TTS. It could happen de novo. So the only way to know about it is to screen for it. How do we screen for it? We said there is an anastomosis, and the anastomosis results in chronic anemia. Chronic anemia. And how can we look at it? We look at 3 areas. Middle cerebral artery, fetal anemia. We look here at the placenta. One placenta is procetic, and the other placenta, other half is pale placenta. So the placenta is almost 2 placenta. One is very pale, and one is very procetic. The same placenta, but they look different. And if you look at the fetal liver, you will see this picture. This is called starry sky liver. I didn't see it before. This is one of my friends gave it to me. Although I see many patients of TAPS, but this picture is very peculiar. This is how we diagnose the TAPS. So in the brain, the cerebral artery, the placenta will be a part of the placenta will be pale and will be procetic, and the fetal liver will look like a starry sky liver. Now, so the most important one is the I was talking about is MCA, and that's why I showed you the video. If you want to do the MCA, you have to do it properly. Otherwise, it will cause more harm than good. So the baby has to be resting. You have to wait until the baby is quiet, and then put your box of Doppler. Make sure your setting for Doppler is right. There is some machine which will give you MCA. If you don't, then you have to look for the size setup. Make sure that you've got the right setup for MCA, and wait until you get regular waves. If the waves are regular, equal in height, then you're getting the right result. So the middle cerebral artery Doppler is critical in the follow-up of cases of TAPS. So this is just showing the video again. I want to emphasize that if you want to use MCA, you have to use it every day. There is no way you can just use it when you need it. Get yourself trained to know how to do it in the normal cases. So this is a diagnosis of TAPS. What do we do for the TAPS? What do we do? Normally, they're mild, and normally we do expectant management. Just wait. Laser is rare, but if you are good at laser and you have it, that will be a very good treatment. But the thing which you and me can do, is intrauterine transfusion of anemic baby. The last thing you could do is delivery. So you have got the options of expectant management if the baby is not severely affected, and deliver at the right time. If you have got laser, do laser. If you don't have laser, do intrauterine blood transfusion. This is one of my old cases, and I was very lucky here because the placenta is anterior, and you can easily go inside the vessels and transfuse blood. I'm not going to go in details about how much to transfuse. That will all depend on your calculations, as Dr. Fattah was telling you, how you calculate the dose needed. But actually, the procedure of intrauterine intravascular blood transfusion is quite straightforward if the baby is in the right position. You can also do something else, which is intrauterine exchange transfusion, because sometimes in these babies, the blood is so sick. So sometimes you have to withdraw blood from the basilic fetus and replace it by saline. So that's what you call intrauterine exchange transfusion or intrauterine blood transfusion. That's what we do for these cases of TAPS. So in the summary of TAPS, it is the chronic transfusions through minute anastomosis. The main diagnosis is MCA, peak systolic velocity. There is a huge discrepancy in hemoglobin between the two babies, and also the reticulocyte count is very different. The mortality and morbidity is quite high. And if the baby survive, there's a very real chance of congenital deafness. So, do we know what is the best treatment for TAPS? The answer is no. It has to be individualized. And if you're not experienced, then you have to consult somebody who's seen patient before. You could not be the first person to treat the first case. You always look for help and advice. So we have TAPS and we have TTS. What's the difference? In TTS, there is an increase in the size of the pregnancy. It doesn't happen in TAPS. In TTS, there is a higher chance of preterm labor, not necessarily in TAPS. The shortness of breast due to bigger abdomen and broader arms does not happen in TAPS that much, and the reduced fetal movement is also confined to TAPS confined to TTS compared to TAPS. So I come back to my original slide. The condition which is confined to micro pregnancy, which is TTS, TAPS, selective IUGR, they can all lead to non-immune hydrops. Thank you so much. Hello, thank you.
شكرا جزيلا بروفيسور بدر، محاضرة رائعة كالعادة، وزي ما اتعودنا من حضرتك straight to the point. We have many thank you from the audience. And now we are going to open the floor for questions.
I tried my best to keep it very confined, because when I was preparing the lecture, the amount of material available is just unbelievable. So I just tried to be as confined as possible.
Perfect. So we have a question from the audience. During which gestational age is TTTS most commonly diagnosed, and can consequent transition syndrome occur late in the third trimester of pregnancy?
TTS can happen as early as 18 weeks. And these cases are normally have a very poor prognosis, because as Fatah was saying at the beginning, the earlier the onset of the disease, the worse the prognosis, because intervention become difficult. Just remember we are dealing with a very tiny human being, inside. And if the baby is tiny, you can imagine that the vessels are even more tiny. And sometimes the equipment is much bigger than the vessel itself. So, but to answer your question, yes, it can develop as early as 18 weeks of gestation. The TAPS is difficult. TAPS you need to look for TAPS. If you have got a going to pregnancy, that's what I do. I deliberately examine the MCA, and I look at the liver, and I look at the placenta. The placenta is quite easy, but doesn't happen except late. The change in the placenta, because it's easy. One will be very pale, and the other part will be very prolific. But that is your main guide to diagnose TAPS is to look at the MCA, big velocity. And that's why the whole thing is about knowing that this twin pregnancy is non-chronic twin pregnancy, and it's a high risk. Because if you don't make that diagnosis at the beginning, you wouldn't be looking for the complications.
Yeah. Perfect. Dr. Tamer, do we have any question in the question and answer box?
I know my topic is
So
quite
far, no.
specified. That's why maybe not many questions. Yes.
تامر لو سمحت انميوت دكتور سامي عشان عنده أسئلة.
There is a question in the chat box talking about selective FGR. What is the treatment?
Oh, that's a difficult question. Now, selective IUGR, if you can monitor them and make the baby surviving and deliver them as early as possible, that will be, in my view, will be the best option. Because second option is not that easy. That you cannot do, of course, laser. What you could do is fetal cord ligation, and that is even more complicated. But luckily, the cases of selective IUGR are not that many, and when it's diagnosed, it's not that severe.
No? كيفك؟ الله يسلمك.
دكتور سامي حضرتك
I would
معانا؟
like to thank Professor Badruddin for the nice, interesting lectures. The audience in the chat has filled the box with a lot of gratitude and thankfulness for your lecture. We really enjoyed it, and they have asked for more lectures from Professor Badruddin in the coming Zoom meetings. We will arrange that with Professor Muhammad Kamal within the platform of the Egyptian Fetal Medicine Foundation. I guess this is the end of our second lecture. Professor Muhammad, should we go to the hands-on or should we take a break? What is the plan now? Tamir?
Yes,
you-
yes, Dr. Sami. We will start 10 minutes live demo. Okay, by Dr. Tami. Dr. Tami, start, please. Thanks, Dr. Bader, for your outstanding lecture as usual, and appreciate your time and always support. Thank you so much.
Thank you so much. Thank you for inviting me. Thank you very much.
Our pleasure always.
My pleasure.
Thanks, Dr. Badr, for your lecture. I will start the live demo. Give me just a few minutes to get things done.
Before starting our live demo session, it's my pleasure to extend my gratitude and thanks to Radwan Company. Radwan is a partner of Samsung Ultrasound Company Medical Ultrasound Department. It's my pleasure to invite my colleague Tamer to start the live demonstration. Thanks, Radwan team and the stakeholders in the company for our usual support of supporting Egyptian Fetal Medicine Foundation and to arrange this scan session to understand how we do the anatomical scan step by step to understand how to approach the diagnosis of any congenital malformation, especially our session today, how to approach the diagnosis of hydrops fetus. Thanks, Radwan, and thanks Samsung company, especially their team in Gulf area. Thank you so much, and I hope for more and more collaboration in the future. Okay, Tamer?
Okay, Dr. Muhammad, I will share my screen now.
Recording in progress.
Is my screen clear? Can you see my screen?
Yes, Tamer, go on.
Okay. First of all, I would like to thank Professor Muhammad Kamal for allowing us to use his device. Our demo today will be using a Samsung machine, a V6 device. We first started our 6-step approach to know the orientation of the baby, the placental location, the fetal availability, the count of the fetuses. And after that, we will continue our examination for finishing the fetal parametry. As you see on my screen, we are now seeing the fetal head. I am pointing to the 2 salami. Here we can see the Fox reply, the lateral ventricles, and the cerebellum. Also, we can see the cisterna magnum. Here is the cerebellum. After that, we will move to the plane where we can get the abdominal circumference. It's plane number 11. We should see the stomach, the part of umbilical vein, and after that, we do the measurements. Is there a problem with the voice?
No timer. No, go on.
Okay. Then we will go for the femur length. We will measure the femur. It's a good practice to optimize our image to make the femur filling two-thirds of the screen and put the calipers in the right position. The baby now is facing us, so we'll take the opportunity to check his face. As you can see here, it is the profile of the baby. We can zoom on our screen to have a good image. Here we can see the fetal mandible, the nose, and also we can check the eyeballs. As you can see here, we can also see the two eye lenses of the baby, which excludes that we have a congenital cataract, also the nostrils, the mandible, and the alveolar margin. I think it is a good position also to check the fetal heart. We start by the abdominal circumference. Okay, then we check the kidneys. In the sagittal view, we can check the longitudinal view longitudinal view of the kidneys. Here is one of the kidneys. We can tilt our probe to check for the other one. Also, in the sagittal view, we can check the fetal spine, as you see here. We check for the integrity of the vertebral column, that the skin above the vertebral column is intact. We don't have any spina bifida. And also this part is very important to check for the sacrum and coccyx to exclude any sacral agenesis. Also, we need to check the fetal limbs. So we'll check our lower limbs first. As we can see here, we are looking for the tibia and fibula of one leg and the tibia and fibula of the other leg. We check for the foot and the angle of the foot. I think it's look perfect. Also, we need to check for the upper limb. We start using the heart as a guide for the position of the humerus. And as we see here, we are seeing the humerus and the radius of ulna of one of the arms. We can also see the hand and the fingers. When we will move them to the other arm. Also check for the presence of the radius and ulna and the hand, and if we are lucky, the baby may wave to us. Next, we are going to check the missing anatomy or the anatomy you haven't checked before. We will go for the heart. It's better to use the fetal heart setting in the device and optimize our image using the zoom box. As we can see here, we first identify the four-chamber view of the heart. And we can see here the LVOT. We are trying to optimize our image. The LVOT is now, we can see it more clear. As you see here, we can see the aortic valve, and after that, the RVOTs, it is crossing on the LVOT. We are seeing that the valves are moving freely. And here we can see the pulmonary artery with its bifurcation. This is the bifurcation. We have some shadow from the fetal limbs. It's a good practice also to use the color flow. As we can see here, we are checking for the intraventricular septum. Also, we can see the LVOT and RVOT more clear using the color Doppler. This is the LVOT. It's much more clear using the color. And the LVOT crossing each other. This is a nice V shape. We will go for some Doppler measurements as our webinar is about fetal hydrops. It's good to do a middle stripper artery Doppler. We start by getting the circle of Willis using our color Doppler. Then we use the pulsed wave and taking in consideration that we are using a good angle. And after that, we get the waves. The waves are equal. We can use 3 successive equal waves for our measurements. What is important for us today in middle stripper artery is to look for the peak systolic velocity and also to use it using the calculators as Professor Sharif said. We will now finish the anatomy that we haven't scanned. We are trying to get the umbilical artery Doppler. Looks nice. We need to have at least 3 successive equal waves, and we look for the RI and BI. I think the baby position will help us to do some volume. We'll try to get the volume of the face to make the mother happy. We will using the box, extend it, and then use the 4D to get a picture of the face, and then after that we are applying the realistic view. One of the options that allow us to get a better image is to use the modification of the light and the direction of the light, help us to get a better image. We will try to get here something better. We can also check for using the 4D or 3D volume to get the fetal limbs It allows us to see the baby moving freely, check for the movements of the angle and the angle of the foot. The baby is hiding. We are trying to use the light to get a better image. We can also use the 3D volume to check the fetal vertebral column. It allows us to take the 3D volume and re-scan or recheck it after the finish of the examination or the movement. I think now we have a clear image of the face. The baby is putting his hand on his face. He is swallowing. Okay, I think that's enough. Thank you.
Thank you very much, my dear colleague Dr. Tamer, for the fantastic live demonstration. We have enjoyed it a lot. And now it's my pleasure and I'm delighted to introduce my dear Professor Dr. Muhammad Kamal, who is a professor of obstetrics and gynecology in Fayoum University with a special interest in the fetal-maternal medicine. Professor Muhammad also is the president of the Egyptian Fetal Medicine Foundation. He also serves as the ISWAG ambassador for the MENA region. Professor Muhammad will talk to us about the non-immune hydrops fetalis stepwise approach. Please, Dr. Muhammad, the floor is yours.
Thanks, Dr. Ahmed, my dear friend and brother. Thank you so much for your kind words. And let me, before start, to congratulate you as the ISWAG nominate you as an ambassador for Egypt, starting from next month, September. Congratulations, Dr. Ahmed. Let me first, I'd like to thank and extend my gratitude to Samsung Medical Health Department and Radwan, its partner in Egypt, for their always support and collaboration with Egyptian Fetal Medicine Foundation in a lot and many courses, workshops, even in the conference. Thank you so much. And I appreciate what you do for us and for education, not only in Egypt, but also in our region, especially North Africa and the Middle East. Thanks, Samsung. Thanks, Radwan. The objective of this lecture, first, to identify those cases that are treatable in utero. The second, deliver the fetus when the benefits of prolonging pregnancy are outweighed by the risk of fetal demise. And lastly, identify disorders with the risk of recurrence in future pregnancies to counsel the parents. As a definition of hydrops fetalis, it is usually there is abnormal fluid collections in the serous cavities and soft tissues, and this group of disease are comprised under the group that not caused by red cell aluminization. The prevalence is variable from area to area. It ranges from 1 per 1500 to 1 per 4000. And the cause of this big variation, a wide variation from country to country, and area from area, may be due to definitions, because in some areas and in some institutes, they consider some other findings like cystic hygroma in the definition and the diagnosis. Regarding population, as you know, some disease like alpha thalassemia, which is the major and the main cause of non-immune hydrops fetalis in Mediterranean countries and Southeast Asian. Regarding to evaluation, it also depends on the institute capability for diagnosis and the advanced genetic department for detection and diagnosis. Also, this different from country to country regarding to the late pregnancy termination. Some reports including only the live birth and other including the IOFD and the late pregnancy termination. Actually, we have many factors that can lead to non-immune hydrops fetalis. And the most important and the first common cause is cardiovascular abnormalities. The second is chromosomal, and also we have different factors and etiologies like hematological abnormalities, infection, fetal infections, thoracic and other congenital malformation. The pathogenesis is there is imbalance in fluid movement between the vascular and interstitial spaces, plus there is decrease in the lymphatic drainage. To diagnose hydrops fetalis, non-immune hydrops fetalis by ultrasound, we need at least two findings. From these findings, which is ascites, pleural effusions, pericardial effusions, and skin edema. Usually in ultrasound, we may find another findings like polyhydramnios, like placental thickness increasing in the second trimester to be 4 centimeter or more, in third trimester 6 centimeter or more. Stepwise approach, how to approach, because we have many factors, how we approach in very simple way. As we know, non-immune hydrops may affect single, twins, and twin monochorionic, dichorionic. Dr. Badr already talked about monochorionic, so my lecture will be about single non-immune hydrops fetalis or one fetus in twin pregnancy, dichorionic twin pregnancy. The first thing, which is very easy for all of us, to start by assessment of middle cerebral artery peak systolic velocity to diagnose or exclude fetal anemia. In very simple way, just we measure the peak systolic velocity, and usually we get it through the ultrasound machine by centimeter per second. We have to change and convert it to know what is the multiple of median of this case. When the multiple of median is 1.5 or more, it means there is fetal anemia. And to do that, the same platform, which is free platform, we can just write the gestation age by weeks and the peak systolic velocity of middle cerebral artery by centimeter in second. After that, we can ask for calculation. We will get the multiple of median in this fetus, and is it normal or abnormal to the normal. In case we found the multiple of median is 1.5 or more, it means there is fetal anemia that leads to non-immune hydrops fetalis. If less than 1.5, so there is no anemia. In case of anemia, we have two possible causes: fetal infection or hemoglobinopathy. Fetal infection represent about 7% of cases, and the most common viral infection is parvovirus B19. And usually we can find another ultrasound findings in the form of calcification in the liver, in the brain. There is microcephaly, ventriculomegaly, growth restriction, hepatosplenomegaly. These are other ultrasound findings we may find it. For diagnosis, we can ask for IgM and IgG and amniocentesis and do PCR for confirmation. In case there is fetal anemia, in this situation, the good news, it is reversible. So we have to do intrauterine blood transfusion as early as possible to avoid heart failure. If there is no fetal anemia, there is no fetal infection, but there is fetal anemia, so we have another possibility, which is hemoglobinopathy. Hemoglobinopathy represents about 12%, and especially alpha thalassemia major. As we know, the alpha thalassemia abnormalities or this autosomal recessive disease are common in Mediterranean area and Southeast Asian. It is due to alpha gene deletion in chromosome 6, and usually it develops severe fetal anemia. In these cases, we can screen both parents for maybe they are thalassemia carriers, and we assess the MCV. If it is less than 80 femtoliter, so it is the diagnosis. Another thing is that we can assess the fetal DNA testing. In this situation, we counsel the parents that alpha thalassemia major has poor prognosis and there is risk of recurrence 25%. In case of the peak systolic velocity is less than 1.5 multiple of median, it means there is no fetal anemia, and this condition we have to assess the cardiovascular system and other detailed anomaly scan. And in this situation, it recommends to refer the patient to specialist in fetal medicine or tertiary center. Actually, the most common cause of non-immune hydrops fetalis is cardiac abnormalities. It represents around 20% of cases, and we have two major subgroups, maybe structure anomalies and maybe fetal arrhythmia. Dr. Amal will talk about fetal arrhythmia and how to manage it because it is one of the reversible causes of non-immune hydrops fetalis. If there is a structure in the form of AVSCD, hypoplastic left heart, VSCD or ASCD, in this case, the prognosis is very poor and the mortality rate is around 100%. And it's important to know that the recurrent risk in this case of congenital cardiac defect is high. It's approximately 5%. Regarding arrhythmia, we may have tachyarrhythmia in the form of supraventricular tachycardia or atrial flutter. May we have bradyarrhythmia, and Dr. Amal will discuss in details about this arrhythmia and the management. So, if we don't have fetal anemia and the fetal echo is normal, we have to search for another congenital malformation. The most common congenital malformation is intrathoracic lesions in the form of CBAM type 1 or 2, which is there is single large cyst. These lesions could interfere with the venous return leading to heart failure, and maybe CBAM type 2, there is multiple small cysts, and also maybe the cause is pleural effusion. In this case, hydrops fetalis can be predicted by using this formula, which is CBAM volume ratio. We need to write the three measurements of the lesion, whatever cyst or solid mass, and the head circumference, and we can calculate this ratio. If it is more than 1.6, it means this fetus is at high risk of hydrops fetalis. We need to follow up the fetus 2 to 3 times per week for early detection, and once we have the signs of hydrops, we start to interfere with the fetus and manage this intrathoracic lesion. If the ratio is less than 1.6, so we have low risk and just we need once per week or twice per week follow-up. Once we found the early stage of hydrops fetalis, we can drain this fluid by needle or thoracoamniotic shunt. If we have solid lesion, we can start by corticosteroid or surgical resection if available, or using the photocoagulated laser if it is available. Regarding pleural effusion, the chylothorax is the most common cause of isolated pleural effusion, and in this condition, we need also drainage of this fluid or putting shunt, thoracoamniotic shunt to drain this fluid. If there is no fetal anemia and no congenital heart malformation, and also there is no intrathoracic lesion, still we have another possibility of other congenital malformation. One of them is skeletal dysplasia, whatever achondrogenesis, osteogenic imperfecta, thanatophoric dysplasia, but unfortunately we couldn't do anything in this case. Maybe there is tumors like sacrococcygeal teratoma, chorioangioma of the placenta, and in this situation, if we have tertiary center and have fetoscope, we can do laser for photocoagulation to decrease this shunting. Another cause may be vascular system, which is AV malformation in the form of malformation of vein of Galen. So if there is no anemia and normal fetal echo, and also by detailed ultrasound scans, there's no congenital malformation, here we have high possibility of genetic and chromosomal abnormalities. And actually, chromosomal abnormalities is the second most common cause of non-immune hydrops fetalis, and the first cause if hydrops fetalis developed before 24 weeks of gestation. It represents around 16% of cases, and usually the aneuploidy is trisomy 21, monosomy X, trisomy 13 and 14. And in this case, we counted the parents that the prognosis is very poor and the mortality is around 100%. Fetuses with structural abnormalities should have genetic testing, and fetal chromosomal analysis, genetic microarray molecular testing should be offered for all fetuses if it is available in our unit. If there is no fetal anemia and a normal fetal echo, there is no congenital malformation, and we get the report from the genetic department, there is no abnormalities. In this case, we still have around up to 25% with unknown causes. The prognosis of non-immune hydrops fetalis usually depends on the etiology, and if we exclude chromosomal abnormalities, the survival rate may be reach up to 48%. Regarding to the pregnancy and the delivery management, we have to counsel the patient according to the etiology and the severity, and if there is lethal prognosis, pregnancy termination is an option if it is accepted in your country. The time of delivery, it's not recommended for elective preterm delivery due to there will be poor prognosis. Regarding the mode of delivery, except if there is some complication or any complication, maternal or fetal, in this case, it's okay for preterm delivery. Caesarean delivery is recommended to avoid birth trauma, and autopsy is recommended in all cases of neonatal or fetal death in non-immune hydrops fetalis. Take-home message: all patients with hydrops fetalis should be referred promptly to a tertiary center. Imaging studies should include comprehensive obstetric ultrasound and fetal echo. Fetal chromosome analysis and genetic microarray molecular testing should be offered where available in all cases of non-immune hydrops fetalis. Again, we may have anemia. If there is no anemia, search for cardiac abnormalities. If it's normal, detailed anomaly scan to exclude other congenital malformation. If it is normal, we have to ask for genetic screening to exclude chromosomal abnormalities. If all of these are normal, in this case, we have still around 25% of the cases with unknown cause. Thank you so much. And if you have any question, I appreciate and I will answer you. Thanks.
Thank you very much, Professor Kamal, for the wonderful presentation. Straight to the point as expected and as always. Very, very hot topic. Thank you very much for this presentation. We are ready to take your questions, and I would like to thank you very much for the congratulations and the warm wishes about my future nomination. Thank you very much.
Congratulations, Ahmed. My pleasure. Okay.
It will not be easy without your support, Professor Kamal. Thank you.
Thanks.
We have a question here: to do the shunt prenatally or postnatally?
Actually, prenatal, because the problem when there is fluid, it interferes with the venous return. So we want to prevent that by shunting intra-uterine, if it is possible. If it is not, so we can do drainage.
Perfect.
Okay.
A lot of thanks on the floor. And there is another question. In alpha thalassemia and recurrent fetal hydrops, can we depend on amniocentesis for diagnosis?
First, we have usually, if there is alpha thalassemia major, both parents should have thalassemia carrier. So we have to start by screening for both parents, amniocentesis if it is available to assess the fetal DNA.
Okay, many thank you for the lectures. Let me check the questions and answer box. No more questions. Dr. Sami, do you have any questions? Dr. Tamer, do you have any questions?
Okay, thank you.
Okay.
Thanks.
Professor Amal, are you with us?
Yes, I am with you.
Perfect. Perfect. It gives me a great pleasure, and I'm delighted to introduce our next international speaker, Professor Amal Sisi. Very well known, needs no introduction, but just to give me the opportunity to introduce her, I'm going to introduce her. She is a professor of pediatrics, Cairo University, with a special interest in fetal medicine and fetal or perinatal cardiology. Professor Amal will talk to us about fetal arrhythmias, early diagnosis, and effective management for better outcomes. Please, Professor Amal, the floor is yours.
Thank you very much indeed for this invitation. Thank you, Professor Muhammad Kamal, Professor Ahmed Khatib, and I'm very happy to be with the rest of the speakers, my dear friends, Dr. Sharif and Dr. Bad. I'm going to talk about the fetal arrhythmias and the importance of the accurate diagnosis to initiate accurate treatment and hence save the fetus. Can you all see my screen? Okay, I presume it's all well seen.
Yes, the sound is clear and the screen is okay.
Excellent. The electrics of the heart, just a brief about the embryology. They starts by the SA node, which gives the electric impulses to the AV node, where there is a bit of delay, and then the Purkinje fibers to both ventricular activation, where we get the QRS, and hence the ECG that we all know. What about the fetal rhythm? It develops by an SA node formed by 5 weeks of embryo age through an antigen. How it was diagnosed by an antigen that is present in the SA node tissue. The formation of his bundle and Purkinje fiber progress with cardiac septation and the embryo level until mature conduction of the system is observed very early, about 8 to 9 weeks post-conception. The normal fetal rhythm is actually around 140 per minute, but it's a range, of course, between 120 to 180. And sometimes there will be slowing of the fetal heart, and that's very physiologic, especially early in pregnancy. Fetal heart rate responds to vagal stimuli, for example, cord compression. And 1 to 2% of fetuses will have a benign ectopic or irregular beat. So this is absolutely benign condition, and they are more common later in pregnancy. The fetal rhythm problems that we are going to talk about are tachyarrhythmias and bradyarrhythmias. The tachyarrhythmias, either they are intermittent and they are very common. The extrasystoles are extremely common in the fetal life and they are extremely benign, or persistent, such as SVT or VT, ventricular tachycardia or supraventricular tachycardia. The bradycardia can be sinus bradycardia, which is of course very bad news, or complete heart block or AV dissociation. Now, we'll start by the tachycardias, and the most common, of course, is the supraventricular tachycardia. It can be by how it is initiated, either by variable atrioventricular block, and hence there is reciprocal activation in the atrium, the right atrium, causing tachycardia. Or there is an accessory, there is also a variable AV block, and there is an accessory pathway giving rise to the supraventricular tachycardia. The diagnosis, how are we going to diagnose the fetal rhythm? Of course, fetal ECG sounds as the perfect way or the ideal way. However, as I will show you, it is not practical way. But we can overcome this by 2D echo, fetal echo, M-mode Doppler, pulse Doppler of inflow versus outflow, SVC versus aortic flow, Doppler of umbilical, venous, and arterial flows, and of course, as well, tissue Doppler imaging. Now, the ECG of the fetus, we can use maternal electrodes, but these ECG will be mixed with the maternal ECG with impulses from the fetal, from the uterine contraction themselves, from the muscle twitches or whatever. So they are not clear fetal ECG. Sometimes they are difficult to isolate. Now there is this very big machine which uses the magnet to record the fetal ECG, which is easier to isolate from the maternal, and it's more clear. However, it is, as you can see, very big machine that is not usually used and is not present in most hospitals. For example, this is how we get the fetal machine by the magnetic cardiography, and that's how we get it by the electrodes. It is mixed with the maternal. So it's not a practical way. So what is the practical way is to do 2D echocardiography, get the usual 4-chamber view, and then get the Doppler across the outflow, which is the aorta. We can see the Doppler here, and the inflow, which is in this case the mitral inflow. And you relate the inflow to the outflow. The inflow represents the P waves, the outflow represents the QRS wave. So we should have an inflow impulse followed by outflow impulse all the time. So that means it is sinus rhythm. Or we can use the M mode. We get the cursor across the ventricle and atrium, any ventricle and any atrium. The waves of the atria is the atrial contraction, and the waves of the ventricle are the ventricular contractions, and we correlate the A waves with the V waves, and this is again sinus rhythm because A wave is followed by a V wave and so on. Here is the same A, V, and so on. This is sinus rhythm. Also, we can use the umbilical, venous, and arterial Doppler. Not very common, but we can use it, and we can detect ectopics because ectopics usually have a negative or a flow opposite direction. Here we can use, we can see another example by Doppler, aortic Doppler and mitral flow Doppler, seeing an atrial impulse not followed by an aortic Doppler and a pause. This is an atrial ectopic. One extrasystole. This is an extremely benign condition. Even if it is repeated, it doesn't cause any problem and usually disappears after birth. So what is this? This is severe tachycardia. And when we say severe tachycardia, it has to be above 200, 220. So as we mentioned, 180, even 200 can be still normal in fetus. You cannot miss it. If you're doing your ultrasound, you will see this severe tachycardia. It is usually supraventricular. You need to prove it by doing the Doppler and the M mode to see that it is supraventricular. So each A wave has a V wave. Now, when we have a fetus with this condition, we have to assess to make sure two things: that there are no structural anomalies associated with it, and the second thing is the complications of this severe tachycardia. This is another video showing the transition. You can be lucky and you see the transition between normal heart rate transition to tachycardia, like this case. And this is the M mode. You can see, you can calculate the heart rate very easily. You can see that each atria is followed by a ventricle. It is conducted through the accessory pathway. So, and only, it's important to note, I mentioned the structural heart disease, only 2% of these cases will have structural heart disease. You can also, this is an M mode where you can see the normal sinus rhythm on the M mode and then transition into severe tachycardia, and you can see the A and D waves are correlated. Atrial flutter is much less common, only 15% of all cases of SVT, and it is more difficult to diagnose. However, atrial flutter has a crescendo decrescendo pattern, so it doesn't continue for a long time. Sometimes it is stopped by its own and usually associated with structural heart disease. Now, the complication, of course, is the hydrops fetalis, which is the subject of this webinar. And of course, hydrops fetalis is a dangerous complication. The routine ultrasound examination of the fetus hopefully can diagnose the tachycardia before it causes this complication, because this complication is associated with poor function, with AV valve regurgitation, with dilatation of all the heart chambers, and it is related, of course, to heart failure. It is extremely difficult to treat the tachycardia when we have hydrops fetalis. The medications may not work because they cannot reach the fetus. It can start, the hydrops, as mentioned by Dr. Muhammad Kamal, can start by only pleural effusion or minimal pericardial effusion, and in this case, it is important to initiate treatment very early. So, what is the treatment of fetal tachycardia? If intermittent, like I mentioned, it is only extrasystoles and so on, or short acting with no complications, usually no treatment is indicated, but close follow-up. If intermittent, or there is hydrops or happening most of the time, more than 50% of the time, we must initiate treatment. Tachycardia with fetal hydrops, of course, is more difficult to treat due to drug distribution volumes and the edematous placental absorption and transfer of the drugs. So what is the first drug we use? We usually, in SVT, we use our old favorable drug, which is digoxin, and we have to get high maternal serum level to optimize the fetal serum level, which is usually 50% of the maternal serum level. And there are a lot of protocols, and each hospital or institute will put their own protocol according to their experience and institution policies. If no response to digoxin, we shift to another drug, or we can combine more than one drug. If hydrops is there, digoxin is not enough. There's also the other drugs that we use is flecainide, and it is effective in 80% of cases. However, it is associated with intrauterine fetal death in 8 to 10% of cases. Sotalol is also effective, also carries a lot of complication like fetal mortality. Amiodarone is potent, but it is associated with thyroid abnormal thyroid function test. So there is no perfect drug so far. This is the Utrecht protocol for treatment of SVT. I will not waste your time with it because each institute will have some modification of these protocols according to their experience and policies. Sometimes people revert to invasive therapy. We can see the needle here going into the placenta, administering IV digoxin for intraplacental, any digoxin for cardioversion of the SVT. Needs, of course, a lot of experience. Okay. Now we shift to bradycardia. Now, bradycardia, as I mentioned, it can be sinus bradycardia due to, for example, sinus node disease. It is very rare. And bradycardia actually is a very dangerous sign. It can be a pre-mortem or a sign in a fetus, or a sinus node dysfunction, which is also a dangerous and rare condition. Atrial heterotaxia, like the polysplenia syndromes, can be associated with heart block. Maternal drugs. Atrioventricular block or complete heart block occurs in 1 per 15,000 live birth, and 30 to 50% are associated with structural heart disease like LTGA, polysplenia, AV canal. Immune heart block can happen in maternal lupus, and this can be diagnosed by the anti-Rho, anti-La in the mother, and also other connective tissue disease, also like Sjogren's syndrome, can have anti-Rho, anti-La positive, and there is recurrence risk of in subsequent children up to 15%. The complete heart block, the non-immune without any structural heart disease, is rare. Just a quick mention of the heterotaxia syndromes, which are called the right and left isomerism. They are bad prognosis. Thank God they are not common. Only 3% of congenital heart disease can be present in absence of any structural heart disease, can be genetic, especially related to chromosome 12. They have very bad prognosis, intrauterine fetal death, low survival, 1 year and 5 year survival rate, associated with immune deficiency and splenic dysfunction. It is important to know this because it's important for counseling the parents. This is the difference between the right and the left isomerism, the association of different congenital heart disease. The neonatal lupus is very important. The most important problem is and irreversible problem is the congenital heart block. The dermatologic problem, neonatal facial rash, will disappear or will improve. The hepatic problem will also improve after birth. The anemia, the neutropenia, the thrombocytopenia, all are reversible except the cardiac heart block. The immune-mediated congenital heart block happens in around 1 in 15,000 live birth, and 1 in 50 birth in antibody-positive women. And there is a risk of intrauterine fetal death, and the majority will need pacemaker after birth. Important to counsel the mother. The anti-Rho, anti-La is diagnostic for the mother. There is a 2% risk of congenital heart block, 16% risk of recurrence. And it typically occurs after the antibodies cross the placenta at 16 weeks, and it occurs between 20 to 24 weeks. The antibodies trigger immune-mediated inflammation that destroys the fetal AV node. What are the predictors of intrauterine fetal death in congenital heart block? The isomerism, 90%, the non-immune with normal structure, the hydropes, and the cardiomegaly. We diagnose the heart block also the same way by the M mode, by the Doppler, and it is important to differentiate, which can be difficult sometimes, between second-degree heart block and extrasystoles, because as I mentioned, extrasystoles are benign. Second-degree heart block, especially in immune-mediated heart block, can be the first sign for complete heart block. This is the diagram of the anti-Rho, anti-La. They carry high risk. If they are both positive, the risk is much higher. What is the treatment of complete heart block? Sometimes we give sympathomimetics, steroids, but they have to be given early before destruction of the AV node. After destruction of the AV node, there is no role for steroid. digoxin if there is a poor function, plasmapheresis, and of course elective early delivery. This is the corticosteroid that can be given when we suspect second-degree heart block. The high risk, the fetal echo must be done bi-weekly from 18 to 24 weeks, because after 24 weeks, there will be no role for treatment, for oral treatment. You can give dexamethasone. If the block is complete, no therapy, just follow up. Plasmapheresis for severe hydropic fetus and early elective cesarean section. Prognosis, of course, if the heart failure is not there's no compensation, there will be hydrops, high mortality. But a lot of these babies are born with heart rate 55 to 60 per minute, and they manage to have their pacemaker in the first year of life. And we have a lot of children with pacemakers that are doing extremely well. Heart failure, this is I'm sure you all familiar how to correlation of fetal heart failure with the risk of intrauterine, the scoring system to the intrauterine fetal death. This is just a video showing very bradycardic fetal heart with pericardial effusion, pleural effusion, and hydrops. Again, same. Points to remember: most referrals of fetal rhythm disturbances are due to intermittent arrhythmias. 80% are the extrasystoles, and they are benign. So to reassure everybody, association with extrasystole and congenital heart disease is very minimal, 1 to 2% only. Association bradycardia is more dangerous than tachycardia. Association with congenital heart disease is 30 to 50%, and complete heart block per se without congenital or immune is 1 in 15,000. That is the incidence. So it's not very common. Thank you.
Perfect.
Perfect. Thank you very much, Professor Amal, for your concise and to the point presentation. Yet it is considered as a very tough topic for some obstetricians. So we have a question from the floor, from the audience, talking about a pregnant lady came in labor, and the fetal heart rate is around 180. Is it normal or not? And when would you be worried and consider fetal arrhythmia and commence treatment?
180 is 90%, 99% normal. Okay, because the SVT or atrial flutter will be much higher than this, will be above 200, 220. But to make sure, we need to know that it is sinus tachycardia by doing the M mode or the Doppler to make sure that each atrial contraction is followed by ventricular contraction. For tachycardia, sinus tachycardia, there is no treatment. There is no treatment needed. And also the other thing that to see if any complication, because sinus tachycardia does not cause any complication. So there will be no complication.
Thank you very much for the answer. And here we go, Professor Sherif Abdel Fattah asking to interact with us with a question. Professor Sherif, please go ahead.
مريم ممكن اعملي انميوت لدكتور شريف، ممكن يكون هو مش عارف يتكلم.
I was trying to ask, but I was not allowed to speak and not allowed to switch the video on again. Sorry. Thank you, Amal, for the very nice presentation. I just want to ask about, would you recommend if you started treatment, digoxin or flecainide or something else, that the patient will be hospitalized to be monitored, and what sort of monitoring would you recommend? Because of course we need to give high dose, so there is a potential for maternal toxicity. So would you recommend inpatient or outpatient management, and what investigations would you recommend?
Well, for the digoxin, it takes time, as you know, to build up. So usually we monitor by if the patient can attend regularly the outpatient clinic. We monitor by the fetal heart rate itself, and also by the maternal serum level of digoxin, or if any symptoms. But that's oral digoxin is fine. So it is done in many hospitals as an outpatient. It doesn't need hospitalization unless there is invasive, of course, treatment by IV digoxin intraplacental or any other drug intraplacental that needs admission.
So no need for maternal ECG, for
No, no.
example, for digoxin.
No,
Okay.
no need. But some hospitals have different policies, but the majority do not admit.
Okay. Thank
Like
you.
a day case who can come and have the sonar, have the blood test, have the vitals, and go back home.
Excellent. Thank you.
Thank you very much, Professor Sharif. Professor Kamal.
Dr. Amal, thank you so much for your outstanding lecture. I wonder, usually we refer our cases with tachycardia or bradycardia to cardiologist, and for myself, I refer to you. My question, would you need from us any investigation to do for the mother before sending you the case?
Depends, of course, what I mean, if it depends on what is the cause of the tachycardia or the bradycardia. Of course, the bradycardia, we need to do all the immune tests and the antibodies and the renal function and the routine things. But for the SVT, apart from associated congenital heart condition, there is no lab test or special test unless it is the isomerism or Epstein or something familial, sometimes genetic testing, special genetic testing for these cases, but not routine, nothing for the obstetrician as routine.
Okay, thanks. Thanks.
Professor Amal, we have another question from the floor. What is the best treatment for supraventricular tachycardia to be used prenatally?
Right. That's a very good question, but I will answer it again. Each hospital or each institute should have their own protocol. For example, I showed an example, which is the Utrecht protocol, because it is a simple, straightforward, easy, available drug like digoxin. So what we do, one of the protocols is start with digoxin. Start with digoxin, high dose, like for the mother, take, for example, 3 tablets per day until you build up the digoxin level in the maternal serum, and it takes at least 5 days to build up to the required level without reaching a toxic level. So she needs the monitoring, as I mentioned. If she lives far, maybe she needs admission, but she needs monitoring of her digoxin level daily. As we give the digoxin until we reach the 2.5, the high level of therapeutic level, which will reach 50% the fetus. It is a very effective drug, but of course, its disadvantage is the narrow toxicity margin. So it's easy to get a toxic level with digoxin. So that's the first drug. Now, the second drug is flecainide. Flecainide, you also need to monitor the level so that you reach the high therapeutic level. It is not toxic, and there is a wide toxicity gap. However, it is associated with intrauterine fetal death. Amiodarone or cordarone is a very effective drug as well, but it comes third after digoxin and flecainide. It has the disadvantage, it affects the thyroid of the fetus. So the baby will be born with hypothyroidism. He can have liver problem. He can have thyroid problem. So you have to deal, because what happens that we have to reach high levels to be able to control this SVT. So there's no perfect drug, and that's why it is variable. Protocols from one institute, it depends on the experience of the doctors in this particular hospital and their propranolol. No, it is not a drug that is given for SVT in pregnancy. It is given post-labor. What I want also to assure the audience that these SVT in the babies, these newborn neonatal SVTs, when these babies are born, they still suffer for it and they receive treatment postnatal, but most of them actually become dormant and become silent, and a lot of them, we stop completely the drugs after 1 year, and they remain so for many years, and only some of them will have SVTs as they are, for example, teenager or older. So it is an important, very important disease that we can control during fetal life, one of the few actually in cardiology, and that has a very good prognosis postnatal.
Perfect. Thank you very much, Professor Amal. One more question, if your time is okay. Some of the audience asking about the selective beta blocker.
Sotalol, only sotalol, not sotalol can be given as well as one of the drugs that's given but in I haven't given it myself.
Perfect.
Okay.
Thank you very much. Any other questions from the faculty?
No, Ahmed, thanks.
So we are going to conclude the International Symposium of the Egyptian Fetal Medicine Foundation about the fetal hydrops. I would like to thank all the audience for being with us in the weekend. They are keen to update their knowledge, especially about the hot topic like the fetal hydrops. Thank you all. Also, I would like to thank the whole faculty. Thanks a lot, Professor Amal. Thanks a lot, Professor Sharif. Thanks a lot, Professor Badruddin. Thanks a lot, Dr. Sami. Thanks a lot, Dr. Dalinda, for sharing me the moderation of the symposium. Also, I would like to thank the main sponsor about the symposium, who is the Radwan company, the main distributor for Samsung ultrasound machines in Egypt. Also, I would like to thank Samsung International Medical for their support in our events. And goes without saying, my deepest thanks and appreciation for Professor Kamal, the director of the symposium, and the president of the Egyptian Fetal Medicine Foundation. Thanks a lot for you all. Also goes without saying, I would like to thank Dr. Tamer Farid, my dear friend and colleague, for the nice and informative live demonstration about the fetal anatomy. And we are looking forward to have future successful events together again and again, and any other scientific events. Thank you very much, Professor Kamal. The floor is yours.
Thank you so much, Ahmed, for your great work in this webinar or symposium. First, I'd like to announce that this symposium is recorded and will be available after a couple of days on our YouTube channel. It will be available for 2 weeks, and after that, it will not be. So grab the chance to see and review the lecture. Thanks, Dr. Sharif, Dr. Amal, Dr. Badr. Thanks, Dr. Dalinda, Dr. Sami, Dr. Ahmed, and Tamer, Dr. Tamer. Also, I extend my gratitude to Samsung Radwan and Innovation Company, the organizing company of for this symposium. Appreciate your time and see you in the next symposium. It will be at the end of September. I hope all of you participate with us. Have a good day and thanks. Goodbye.
Thank you very much and
My
bye-bye.
pleasure. Bye bye. Bye.